Hello, my name is Michael Wallace. I'm a gastroenterologist and interventional endoscopist and professor of medicine at the Mayo Clinic in Jacksonville, Florida. I'm also the former editor of Gastrointestinal Endoscopy, so it was a special treat for me to receive an invitation from our current editor, Dr. Doug Adler and Stephanie Kennan, to write an editorial on the best of artificial intelligence in gastrointestinal endoscopy. This is actually the second time I've done this now. We did it last year. And as many of you well know, this field is moving very, very fast. And the number of research articles published in this field and broadly in healthcare is really rising exponentially. So it's hard to keep up with this. And so my goal today is to provide you a list of really the most important articles in our field of gastrointestinal endoscopy relevant to AI advances. So put your seatbelts on and hang on, and we're going to go for a fast ride through the last 12 to 24 months. I think many of you have noticed in your practice that AI has now become a reality. We have AI systems in our endoscopy suite. We have AI systems in our clinical practice. We're using AI systems extensively in our business operations, back office management, and increasingly in our workflow optimization. I think in some ways it's remarkable that we have these tools available in such a short time frame. On the other hand, we sometimes get a bit frustrated that it's not moving even faster. We hear about all of the incredible potential tools of AI in our lives, including our role as healthcare providers and gastroenterologists and endoscopists. And yet, the reality is at least in the field of endoscopy, we currently really only have a couple of tools that are FDA approved and in widespread clinical practice. The most obvious of these is systems available for computer-aided detection of colon polyps. These have been around now for several years, and they were the first tool to be approved by the U.S. Food and Drug Administration for clinical use in the United States, Europe, and really available throughout the world now. I think what's new in this field is the growing amount of well-controlled randomized clinical trials, and importantly, real-world evidence. So we saw in the first couple of years of this multiple randomized controlled trials. We now actually have more than 25 randomized controlled trials looking at so-called computer-aided detection, or CAD-E, to improve adenoma detection. And virtually all of those trials are positive, and meta-analyses of those trials are strongly positive, showing a significant improvement in adenoma detection. Now, most of those have also emphasized the fact that we're really detecting primarily smaller and perhaps less clinically relevant adenomas. Although most of the studies also suggest that they pick up so-called flat adenomas that are the ones that are particularly difficult to detect with our current methods. And we know from historical literature that every gain in adenoma detection rate, whether it's a small polyp, a flat polyp, or a larger, more advanced polyp, translates into a reduction in colorectal cancer incidence and colorectal cancer death. So we don't have the ability at this point to really distinguish what is a critical adenoma to detect and what's less critical. So at the moment, we assume that really any adenoma detection improvement is clinically important. What's really important now is that we have real-world evidence of these tools in our clinical practice. The first of these studies actually was a concerning negative study out of the group at Stanford University that suggested when they implemented one of these tools into their practice, it didn't improve adenoma detection rate. Although now we have at least 5 and a rapidly growing number of other real-world trials, including one that's coming out from the U.S. Veterans Administration, which will be by far the largest to date, in fact, larger than all other trials combined. And we have preliminary results of those studies, including the VA trial, suggesting that there is a true gain in adenoma detection with these systems when they're in use in real-world clinical practice. In addition, we have the so-called computer-aided diagnosis systems, CAD-X. We've been trying for more than 2 decades. I've been very involved in some of the scientific studies trying to distinguish adenoma from hyperplastic. We showed that we could do it with even older technologies, simple chromoendoscopy, the narrowband imaging, and all of its other related imaged enhanced endoscopy tools came along. These systems work really well, but they primarily work well in expert hands. And what's really remarkable about the CADX systems is that they're allowing the knowledge of an expert of saying this is an adenoma, this is a hyperplastic polyp, to be available to everybody, whether you're a fellow just learning colonoscopy or a true expert who's done tens of thousands of these. I think the big question is, will we adopt strategies where we remove some of these small polyps, perhaps in the proximal colon, and discard them without pathological analyses? I think that's still something that hasn't gained traction. But I think what has gained traction is the small polyps in the distal colon, particularly in the rectus sigmoid, that appear to be likely hyperplastic. We know these have essentially no malignant potential, and sometimes there's very large numbers of these, which can be a large burden on the physician to remove, and also increases the risk of bleeding and time of the procedure for the patient. So these systems, I think, are well suited to allow physicians who perhaps are a little bit on the fence about not removing tiny, diminutive hyperplastic polyps in the rectum to go ahead and consider that. And we even have some guidelines from our societies, including the ASGE and other societies, that if you're very confident that a polyp's a hyperplastic polyp, 5 millimeters or less in the rectus sigmoid, it's quite reasonable to leave that in place. Some of the other newer systems have to do with some workflow optimization. One of the difficult parts of these computer-aided detection systems is the so-called false alerts. We get a lot of green boxes that pop up, most of the time on polyps, but some of the time on things like bubbles, folds, a little bit of remnant stool in the colon. And these cause alert fatigue. And they're just frankly annoying when you get lots and lots of these alerts. Fortunately, each of the companies that makes these has now produced second, third, and fourth generation software systems. And these are now reducing that false alert. So if you haven't been using these systems recently, consider using some of the more updated systems, because the false alert rate is going down a little bit. You know, back to the computer-aided diagnosis, we talked about hyperplastic versus adenomas, but one of the key issues is with large flat polyps, where we're thinking about doing an endoscopic mucosal resection. Maybe it's a 2 or 3 centimeter polyp. It's maybe got a little bit of central depression. Maybe you're not sure if you should send this to a surgeon, schedule it for a later ESD procedure, or attempt a piecemeal EMR. Increasingly, these CADX, computer-aided diagnosis systems, are capable of making that distinction very accurately, even more accurately than some of the experts. So we know that people who spend their lives looking at these flat, subtle features of a polyp are quite good at that, although not perfect. I would say even after many years of doing that, even the experts aren't perfect. And I think the computer-aided diagnosis systems are increasingly capable of making that distinction. It's a superficial non-invasive flat polyp, okay for piecemeal EMR. It is a superficially invasive polyp, more appropriate for ESD, or it's a deeply invasive polyp, which really needs to be sent for surgery. Let's now turn to some of the perhaps more mundane, but still very useful things that we can do with AI systems. So one is bowel preparation. There have been a number of projects looking at how we can improve bowel preparation, beginning with how we can actually coach the patient through the most difficult part of the procedure, which is bowel preparation. Several recent studies, even one just very recently, in fact, published since we published this article in GIE, so it's not listed in the references, have shown that chatbots, which integrate with the patient, can reduce the volume needed for their bowel preparation. It was an interesting study because the patients actually uploaded photographs of their bowel movement in the toilet bowl as they started to take their prep. And as their bowel movements got more and more clear, it said you can start to reduce the prep you're taking. And when it got completely clear, the chatbot said you can stop taking your prep. And the control group, it was a randomized controlled trial, just took the bowel prep that was prescribed, in this case, a 3-liter bowel prep. And what it showed is that the chatbot guided bowel preparation reduced the need for the 3 liters. In fact, it reduced it by about 500 mLs to about 2.5 liters. So I think all of our patients would appreciate this if they had to take less volume. One of the other systems related to bowel preparation is we obviously need to wash the colon well to make sure that we see all of the relevant polyps and other findings. A recent study which gave a real-time feedback on bowel preparation said that, this area is not as clean. Perhaps you want to wash this a little bit more. And when that real-time feedback on the bowel preparation was provided to the endoscopist, not only did it improve bowel preparation, it actually improved adenoma detection, including significant polyps, more than 5 millimeters, likely because they're just washing better. Let's now turn to upper endoscopy. The first couple of papers we reviewed were related to detection of H. pylori. Now, arguably, H. pylori we can easily detect by biopsy. We can do it by breath testing or stool antigen testing. There's plenty of ways to check for H. pylori, but often when we're doing an endoscopy, if the patient has dyspepsia or perhaps they're under surveillance for stomach cancer, we routinely take samples for H. pylori. But AI systems can actually detect that and do it very, very well. In the paper we discussed in this article, it achieved expert level accuracy with sensitivity over 90% and a specificity very close to 90% for detecting H. pylori, which is actually quite similar to the random biopsies we take. Other upper GI applications that are common, screening for early gastric cancer or screening for Barrett's esophagus or squamous cell cancer have also been recently addressed, and we discussed several papers where CAD-E, computer-aided detection systems, are increasingly able to detect early gastric neoplasia. This is increasingly important even on our US audience. We've recently published some guidelines on screening high-risk individuals for early gastric cancer. Many of our US population come from areas of the world where gastric cancer is endemic, and they are at risk, particularly for their first generation in the United States. So they should be screened for early gastric cancer. Similarly, in Barrett's esophagus and squamous cell cancer, we continue to see multiple studies demonstrating that CAD-E systems are able to detect Barrett's neoplasia compared to expert levels and are superior to non-experts at Barrett's neoplasia detection. This is important because we know that there's a miss rate. We know that there is, like post-colonoscopy colon cancer, there is post-endoscopy esophageal cancer. And if we can reduce that miss rate of low-grade and high-grade dysplasia, we can likely reduce that post-endoscopy esophageal cancer. And I think there's this theme that is becoming quite common in the field, which is the AI systems bring us all up to expert level. In most cases, they don't surpass expert level, but in many of the studies, in fact, most of them, I would say, the AI systems bring us up to expert level. Now turning to pancreatobiliary endoscopy, I think the literature continues to grow on EUS and ERCP for pancreatic lesions. A nice study which we reviewed is the role of EUS in subepithelial lesions of the stomach. These are typically either leiomyomas, which are almost always benign, especially those that are smaller than 3 centimeters, and GI stromal tumors, which have a higher malignant potential. So we often have to do a core biopsy and special stains to distinguish those. A simple AI model was able to achieve a very high level of accuracy, approaching 90%, in distinguishing these two important findings. Also, some of the things that are helpful with workflow optimization, predicting when ERCP will be a difficult cannulation, and perhaps adjunct methods may be used. Certainly, consider using preventative measures for post-ERCP pancreatitis when we know it's going to be a difficult cannulation with multiple cannulation attempts. So I think we continue to see improvement in that literature. Next on the list was capsule and small bowel imaging. One of the very first papers that we reviewed some years ago was on small bowel capsule and how you could train AI algorithms to detect the relevant lesions. This is a perfect application for AI because we have hours and hours of video that is just normal findings, and often seconds of video where there's a relevant lesion, such as a small bleeding angioectasia or a polyp or an ulceration associated with inflammatory bowel disease. So we continue to see studies demonstrate that AI systems can look at these hours of video, reduce it down to just the minutes of video that are relevant, and they can do this without sacrificing accuracy. So they have a very high level of sensitivity while preserving good specificity. Some of the other recent advances have been magnetically controlled gastric capsules or small bowel capsules, where you can literally drive the capsule through the stomach with a joystick. And these have been combined with AI systems to also improve the detection of these lesions, and also really opens this up to potentially non-physician performance of these procedures, something we're doing in our own practice, where we have special trained nurses do the magnetically controlled video capsule for the physician later to interpret. Lastly, turning to inflammatory bowel disease, we all know that patients with inflammatory bowel disease have multiple endoscopic questions at hand. Are they in deep remission? Is there dysplasia in the colon? Is it ulcerative colitis or Crohn's disease? Where should we biopsy? We take lots and lots of random, relatively low yield biopsy. So fortunately, we've seen several papers, and we highlight one here in terms of surveillance of patients with chronic inflammatory bowel disease for dysplasia detection. We're increasingly moving away from random biopsies towards image-guided biopsies. And along that trend, we're moving towards AI-enhanced or CAD-E enhanced guided biopsies. And we talk about one of the papers that shows that, again, this achieves a very high level of accuracy. One of the things we didn't have the time to talk about in this article are some of the workflow optimizations that are happening in our clinic, but also in our endoscopy suite. AI scribes are increasingly being used in our clinic. And we're going to see in 2026, I think, a number of AI scribes available in endoscopy. We know that these improve efficiency by recording what's happening during a patient visit, or in our case, an endoscopy, and creating the note. That may seem like a mundane task, but we spend often 5 extra minutes every case doing that, which is 5 less minutes we can spend doing more important things. So keep your eyes open for increasing changes and applications of AI in 2026. But I hope this article highlighting the best of 2025 will be useful for you. There's a number of very important references. We've got 20 different articles that we reviewed, almost all of them from the last 12 months. From a variety of journals, GIE, as well as many other important journals. Thank you again. It's been a pleasure to do this interview with you, and hope it was very helpful for you.